Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in this video of a patient who has bilateral deeply located earwax, and in this their right ear, which is the worst out of the two, it's fully impacted and embedded onto the ear canal. And I'm kind of giggling as I say that, and I'll explain why I am. In their left ear, there is deeply located wax, but it's semi-occluding. So this patient is a regular patient, and as soon as they walk in, without me even having to ask, they put their hands up each and every time and admit to using a Q-tip or cotton bud, as we call it in the UK. And the patient knows not to, and it can get frustrating because by doing so, they make the procedure so much more complex. This wax is up and embedded and squashed and rammed right up to the eardrum, and it's somewhat cemented itself, and it just makes it so much more difficult to remove because we know the eardrum is somewhere just behind this wax. So if you're applying too much pressure, you're going to cause some trauma to the patient. At the moment, we don't know exactly where the eardrum is, how thick this layer of wax is. It just adds to the complexity. And of course, we're working on the sensitive, bony part of the ear canal. The inner 2/3 of the ear canal is made up of bone, and sitting on that bone is a wafer thin layer of skin, less than 0.1 millimeters in thickness, which means if you do come in contact with the bony part of the ear canal, it can be really uncomfortable. And I'm speaking from experience. I've had, during my training, someone take an ear impression of my ear, and they've poked the little instrument tool that's used to push this piece of cotton wool into the ear, not deep. It should just go, well, sometimes it depends on the impression, but it's got a string attached to it. And we use that to occlude the ear canal where we take an ear impression so the impression material doesn't leak deep into the ear and attach itself to the eardrum. So I've got no choice here. I'm having to use the right angled correct. And you can see I'm just gliding it in and behind the wax and resting it against the canal wall. I don't ideally want to use manual instruments this deep and up against the canal wall if it's avoidable, but I had no choice there. So I've called this patient Mrs. Cotton Bud, and we had a little giggle about it. And I mean, she's doing well in the sense that when she previously attended, and again, I'm just laughing, and we shared a joke about it. I mean, she knows it's wrong, and she doesn't need me telling her. I don't know why she does it. It's not because it is itchy. I think she just panics when she can't hear a little bit and just reaches out for the cotton bud. And she does amazingly well, truth be told, getting the cotton bud in her ear because the ear is so narrow, the entrance, particularly her left side. So yeah, this patient used to always attend with an ear infection as well, and that's because they always used to get water in the ear. So and it was several years that I've been attending the patient not to get water in their ears. And in the last couple of visits, they've been listening, and the general ear health is far better. They haven't had an ear infection since they've avoided the use of cotton buds. But yet, this is this patient's new nickname, Mrs. Cotton Bud. And I've just used the Rycurette again, and I've gone to the roof of the ear canal. I've just separated it, and I can see a bit of the eardrum now, top left, about 11 o'clock, which is going to help me no end because I know how thick this layer of wax is, and skin, and I'm better able now to maneuver this out the ear. But it's still a challenge. It is so rammed, and they have got quite a narrow isthmus. You'll see, you can't see that at the moment because of the wax, but when I remove this, you'll see the ear canal does narrow on the right hand side of the ear canal. That's the anterior canal wall, and then it widens again. Once more, I don't really want to use manual instruments this deep, but I am going to, in a moment, get the ear hook right up against the eardrum, there or thereabouts, and try and kind of pull this away. So we have put some olive oil in already. You can see some of that on the left hand side. It's seeped through underneath the skin. So I'm having to stretch this patient's ear wide open, dilate it. I'm using the left hand side of the endoscope, almost like a door stopper. So I'm pushing the endoscope, the left hand side of it, to the left hand side of the ear canal to keep that entrance open so I can insert the instrument. So I've gone in with the ear hook. Now, the good thing about the angled ear hook, because it's a 90-degree bend, the pointed bit is kind of going to be away from the eardrum. Is if anything, it's going to be more likely to make contact with the front part of the ear canal now. Although I didn't remove the wax, I managed to glide the ear hook in and kind of dissect it. So this now makes the piece on the right hand side much easier to remove. You can see that incision in the middle, and that's separating. It's going to help me separate this plug of wax. So we're having to take this out in little pieces. So we still can't fully see the eardrum. I think I'm just going to try the Raithatha at the floor of the ear canal, but it's just a tooth and a layer. I'm trying to get in and behind. I did lift it a little bit. You can see it came away, but it's not really going to dislodge this plug. But I'm just going to try here on the posterior inferior canal wall. And because of the angle of the Raithatha, it's got a curve that mimics the ear canal. So yeah, it did lift away, but it's not going to be significant. So I've abandoned that because it's not going to add anything to, or help me remove this plug. So I've just put some more drops in. There's a bit of blurriness. I'm just getting the excess oil out. And because I've removed a lot of the wax around the edge, this oil's now penetrating deeper. And I'm going to get a suction grip in a moment. It's going to come away in one piece. I'm just sort of trying to find the right place. You can, when you're performing the procedure, you can sense which is the right place. And I think I've just hit the spot there, and I'm going to just check. I don't want to come away too quickly with the suction probe because I've got an airtight seal now, which maximizes the suction. If I come away too quickly, I'm going to lose some of that suction grip. And now it's just got trapped at the entrance. So their ear is extremely narrow. And the left ear is a really good example why many specialists do struggle to use an endoscope, because it was even narrower. And so that's why I developed the wax scope, because with the wax scope you can use the specular to widen and dilate the ear canal. You see there's a blister to the left-hand side of the ear canal. The eardrum did kind of move in a little bit there, you can see. So just going to use the fine end to remove this last bit posteriorly. But yeah, they've just got a blister just on top of this piece of wax and skin. So they did, it looks like it's healing well, but no doubt that's because of the use of the cotton bud. So this is a prime example why people can struggle with the endoscope. So this entrance is very narrow and very bendy, and now you can always ask the patient to stretch the ear open for you, and we do teach that. I do teach that to people that attend our course, just in case they really struggle. But some patients won't be able to do that because of, they may have arthritis or bad shoulder, because they're having to use this is their left ear, and to stretch the ear open, they have to get their right hand over the back of their head to pull their left ear back. If they use their left ear, which is the side of the ear that I'm working in, to pull the ear back, the hand's in the way, so I can't use the endoscope or instrument. And the way we do this, I've used the right hand side of this endoscope to stretch the right hand side of the ear canal. I'm stretching it to the right, I'm opening it up. I'm then using the suction probe to kind of also to stretch that back part of the ear canal wide open, so I can then insert it. And the key is, when we insert the instrument, we don't want to clip the side of the ear canal. So that's it. So it is quite a tricky skill, but hence why we've developed the wax scope as well. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.